Morning, everybody. So I'm going to move on to the content slide if we can. There we are. I'm going to discuss the role that human factors or non-technical skills have to play in our surgical practice. And I'm going to try and get into sort of what the term means, which is probably the tricky bit, and how having some understanding of it might help us to optimize our own performance. So I'll look at the impact, but sometimes not quite getting it right can have, touching upon concepts like psychological safety within a department or institution. And finally, how we can look to mitigate against or protect ourselves from the inevitability of surgical error. So you may or may not recognize this area. You probably can't see you might see my cursor. So this is Paddington train station in central London. And I'm going to start with a little story. So get the cursor back. This is St Mary's Hospital in North London. So in 2011, so I was fresh out of medical school and I just moved to London to start my first job as a junior doctor. And I did vascular surgery at St Mary's. And I had no idea at the time, but vascular surgery at Mary's was quite an infamous rotation. It was a big vascular unit and it received referrals from some of the most complex cases around England. And it had some quite famous vascular surgeons there. Some of you might have heard of the war surgeon, David Knott. So he was there at the time, and I think he still is as well. But there's plenty of big personalities. And once a month, there was a grand round. It was a bit different to this one. So it was like a giant ward round. So all the vascular consultants and their teams, so all their juniors, meet on the ward in the morning on the vascular high dependency unit. And each month, one consultant, so attending, leads the entire ward round, and one junior doctor is assigned to present the patients on the vascular HDU to the consultant in front of everybody that morning. And I would argue that, that alone, that sort of scenario, is quite an intimidating and stressful environment for the junior doc presenting the cases at the foot of each bed in front of everybody. And just for some added jeopardy, the junior doctor wasn't allowed to use any notes, so they had to describe the case, including details of often quite highly complex vascular operations that each patient had from memory. And then there was the questioning or cross-examination as well. So on this particular day, my friend Sarah was the doc presenting, and like myself, she'd only been a doctor for a couple of months. And the cherry on top for poor Sarah was that the consultant leading the grand round was also the head of the department. And he wasn't known for being the most relaxed and easygoing individual. And I can actually still remember it now. There was quite a lot of tension in the room. I could feel it. All the registrars and everyone were slightly on edge because you never quite know what's going to happen. Sarah was obviously very anxious, but she did a really excellent job. She moved around all the patients, presented them to the consultant one by one. She's really fantastic. But at the end, when she was presenting the last patient, Sarah was starting to become visibly upset, I think, because of all the tension had been building. She'd done a great job. The consultant had been stern but polite, nothing unprofessional at all perfectly, amicable, reasonable. So why was this? And I think that despite the reputation for surgical excellence of the unit, the culture and environment was well known, actually, for being problematic and often confrontational. And there was a sense that this ran through the department and the clinical teams. And although I made some really good friends while I was there, which I'm still in contact with now, but I think we all worked under a slight cloud of sort of mild anxiety about making any mistake. And there was definitely a sigh of relief on my part when I left that rotation and moved on to my next job. So in complete contrast, the following year I worked here. So there's a second story, but this one's a lot shorter, so it's just a quick one. So this sort of grey, depressing looking building is Northwick Park Hospital near Wembley in northwest London. Actually, incidentally, my sister was born there as well. And I started working here in 2012. Now, Northwick Park had a reputation for being quite a hectic place to work. I think at the time it had the third busiest emergency department in the country. But trainees liked to work there. It was quite a popular rotation. And as part of our first day induction into the hospital, we had the customary presentation, welcome from the hospital's clinical director, who I think was an intensive care consultant at the time. And back then, inductions were all in person, so all the new doctors to the hospital on any given day, and the changeover days the same every year, from any specialty, any grade, had the same hospital induction. So we were all in the same room together. And I remember, I don't know why I remember this, but I still remember the clinical director giving us a little bit of a pep talk. And he said, this place can feel a little bit like a war zone at times. You'll be down in the trenches, but your consultants will be down there with you. And that gave me an immediate sense of camaraderie after he said that. I think, I've got a sense that we're all going to have to work hard and roll up our sleeves, but our consultants are going to support us. And that's exactly what the year there was like. Completely different to vascular at St Mary's back then. And it was a great year at Northwick. So what I've tried to highlight is that whether it's within a department or whole organisation, I think the ethos which is generated from management and leadership has an enormous impact on the way in which the individuals within the department work, and subsequently, as a consequence, patient care. So what are human factors? I think this is probably the most difficult question of all. It's an enormous subject, and it encompasses things like systems design. So how systems are sort of designed, put in place to reduce the chances of error, ergonomics. But I think the key's in the title, really. It's the human element, it's behavior, how we interact with others, communication, and situational awareness. But it's hard to pin down. What is it? Where does it start? Where does it end? But I think the bottom line is that it's about improving patient outcomes. When people realize it's about improving patient care, I think it gets most people on the same page. I met this gentleman a couple of years ago. This is Professor Peter Brennan. He's a maxillofacial surgeon in the UK. And he's done a lot of research looking at the role human factors have to play in the surgical setting. And I've used quite a bit of his research and opinion pieces to help with the talk today. I just wanted to mention him. Certain industries that we're all aware of have looked at this in great detail. So the airline industry classically, but also elite sports. And although I don't think we should necessarily compare or try to emulate elite sport or the airline industry, there is a common feature here, which is human performance. And there are certainly similarities between sort of us and them in terms of industry. But it doesn't all translate, but I think there are some lessons that we can take where applicable. The airline industry is obviously a very high risk industry, which has historically worked very hard to address any factors which are detrimental to performance in order to optimize their passenger safety. And they identified this concept of the cross cockpit gradient, where there was a steep hierarchy historically between captains and co-pilots, and this was identified as a threat to safety. And then elite sports like Olympic teams, F1 racing, if you look at them, they're always looking about how they can get the absolute best out of people, and so that the team can perform the best they can. And then sometimes I look at the way that we work. I'm talking about the NHS here in the UK. And sometimes it looks like we're trying to do the exact opposite. How hard can we make it for you to do your job? And I think if you ask anyone working in the NHS, everybody's probably got a story. Why is it so difficult to do something so simple? So Professor Brennan and a group of Max Fax surgeons and trainees went down here, down to this is Henley Rowing Club on the River Thames, and you can see lots of gentlemen wearing their Panama hats. And British Olympic rowers and the Max Fax surgeons all got together in Henley Rowing Club and completed a validated questionnaire to explore how they perform under pressure. And certain psychological skills such as mental toughness, motivation, self-belief are reliable indicators of performance under pressure, as opposed to personality traits which were found to be unreliable or unusable. The rowers tend to respond with more mentally tough responses than surgeons did. But also the rowers, interestingly, they put an emphasis on overcoming frustration because it can undermine confidence and focus. And they viewed the actual act of being positive or having a positive mental mindset as a discipline. However, some things like internalized self-drive and self-belief, which are important for rowers, not as desirable in the clinical setting, I don't think, where reflective learning and an MDT approach are more utilized. Checking an email or just coming off a Zoom meeting, hopefully not this one, which really infuriates you just before you're about to operate, probably doesn't put you in the best frame of mind going into that operation. And I think sometimes we operate for a prolonged period of time without taking any breaks. And it's worth thinking about whether we would drive from Vancouver to Kelowna, for example, without stopping for a break. And I think if you do have a short break, we don't do this very often, but occasionally I've worked in places where they do this during a long operation. I think you actually make up the time. Hydration is also really important when we're talking about optimizing surgical performance. And I was quite surprised by some of the things I read about this. So if we lose a kilogram of water over the summer, for example, or perspire a lot wearing PPE or lead gowns, your analysis and decision making actually falls by about 15 to 20%, depending on what you read. When you were dehydrated, the way we process information deteriorates slowly, and we don't really realize it's affecting us. So why is this relevant? I think because it happens to us not infrequently. There was a BMJ study that found that the urine concentration of junior doctors in an intensive care unit working in ITU was more concentrated than some of their patients. And some of those doctors were found to be at quite high risk of acute kidney injury. The other thing that's important is eating regularly. So if we're busy, we miss meals, we operate over lunch, and we end up burning ketones. We get a little bit hypo, unscrub, have a Mars bar or something, and then get an insulin rush. And we're just not optimized if we're doing things in that way. If we're hungry, we're more likely to get angry, and then we're 30% more likely to make a mistake, not to mention the effect it has on the rest of the team as well. And people are also looking into whether we should have an operating list straight after a really busy week on call or a busy night on call where we've been up all night, when perhaps we're tired, not rested. When, some people might hear that and think, hang on a minute, are we on Star Trek here or something? In our day, we used to operate all day, all night, have a cup of tea and carry on. But I think the adage applies, but just because you got hit by a truck doesn't mean I should get hit by a truck. We do a difficult job, and I think we need to make it as easy as possible for both ourselves and our patients. And the focus really should be about performing the best we can, not overcoming the most adversity. this is Neil Oakley. He's probably the best technical robotic surgeon I've ever seen. And he also happens to be a fantastic trainer as well. And he's got a number of mantra, which he likes to quote often in the OR and elsewhere. And I put a couple of these on the slide, but one of these is never operate with a full bladder or empty stomach. And for years, this was all I had to base my sort of big cases or pre-cystectomy snacks, last minute toilet trips on. But as I've highlighted previously, on the previous slide, I think there is some evidence for this as well. So I wanted to briefly move on and discuss this concept of psychological safety, which is new to me actually. I did a bit of reading about it more recently, just in preparation for this talk. And this concept was described in a book. I think it's a bestseller by Amy Edmondson from Harvard Business School, called The Fearless Organization, which some of you may or may not have read, but I definitely recommend to anyone that's interested. So, what do we understand by the term psychological safety? It's not immunity from consequences. Individuals might receive performance feedback that includes not meeting certain objectives. But in psychologically safe workplaces, people aren't hindered by interpersonal fear. They feel able to be candid. They're comfortable sharing concerns without fear of retribution. And this allows mistakes to be reported quickly. She found that it's not enough just to hire talented people and expect an organization to thrive. It's also important that we create the right environment to allow this to happen. And to demonstrate this, when Amy Edmondson was doing her PhD, one of the things she looked at was medical error rates over a 6-month period between various hospital teams in the context of team working effectiveness. And she found the teams that scored highest in terms of team effectiveness and good team working skills had higher medical error rates. It's a bit confusing, but when she looked more closely at this, it was because the better performing teams reported more errors. So the best performing teams had a culture which promoted psychological safety. So colleagues felt able to speak up. They reported errors when they occurred, and they found that teams varied dramatically about whether they felt able to speak up and report mistakes. What effect does the relationship between human factors and leadership and hierarchy have on surgical performance? So there's plenty of descriptions and discussions in the literature about flattening the hierarchy, this concept of flattening the hierarchy. Every team has a captain, and everyone on the team needs to feel that they can speak to the captain. But surgical teams need some hierarchy, and incorporating human factors and psychological safety are not just about flattening the hierarchy. We need to know who's taking us forward, particularly in difficult or stressful situations. And actually, I think no hierarchy at all is more dangerous than a steep hierarchy. But we must be able to challenge, to ask advice, and particularly when there's patient safety concerns, whilst acknowledging that with steep hierarchies, people can feel unable to speak up. And that's where problems can arise. I think it's easy to think you're approachable as a surgical leader, but trainees can be naturally guarded about making suggestions or criticisms about management decisions or anything in the OR or clinics, wards, because they're likely to consider, what's the risk to me or what's the risk to my training if I raise this? But that balance between having authority but also approachability, I think, is really hard. So what are some of the challenges we face at the moment? I think there's definitely personal challenges, interpersonal challenges. It's not always easy creating the right environment and getting that balance just right. But part of the nature of our work involves being confronted with stressful situations, and how we respond to stress and frustration is pretty well established, and has its roots in the limbic system of our brain. All of us are susceptible to outbursts of anger in the heat of the moment. You might remember Nick Kyrgios smashing his tennis racket in the US Open, or if somebody cuts you up on a ski lift, or repeatedly hands you the wrong instrument in the OR. It's the limbic system which can take over, this idea of going chimp, and it's responsible for fright, flight, and fight. And this is thought to be the product of the development of the reptilian brain about 500 million years ago. And what happens is something called limbic hijacking occurs, which overrides higher functions, which developed about 100,000 years ago. 80% of people regret their actions afterwards. So most of us regret shouting out or being uncivil after the event. But it's very difficult to teach patience. I'm not sure if you can even do that. But you can teach about limbic hijacking, and people do that. And they try and teach stopping, if safe to do so, stepping back from a situation where possible, obviously not always possible in the sort of environment that we work in. But if the same thing's happening, again and again within a team, it's probably sensible to look at what's happening here and why the team isn't working. It's not usually just one individual's fault. To help mitigate this, there are some anticipated parts of some operations that we know are going to be either a bit tricky or a little bit more stressful for a period of time. And these can be highlighted at the team brief. Mini briefs are also really useful for certain operations. I've seen these used before partial nephrectomies, before clamping. So have a little mini brief during the op, check all the kits available, everyone knows what they're meant to be doing. And I saw Ben Chalacoon do this really effectively just before clamping during a partial nephrectomy at the European Robotic meeting in Barcelona a few years ago. Whereas all the other presentations during that meeting over the weekend and live operations, the focus was really about the technical aspects of the surgery, which Ben did as well. But Mr. Chalacoon was the only surgeon that I saw to make a real show of highlighting the mini brief and getting everybody on the same page before a crucial step in the operation. So I think that's useful and was worth considering. I was quite impressed by that. The age of robotic surgery is amongst us. So I think robotic surgery has created a whole new set of challenges, or communication challenges, in the OR, where we lose a lot of the non-verbal cues which we were used to in either open or laparoscopic operating, basically because of proximity. We can't always hear the robot console microphone well, which can be frustrating for the surgeon, frustrating for the bedside team. And because of the change in proximity of the robot room, we don't easily notice changes in body language when things are more stressful or getting to a difficult bit. So it's worth considering ways that we can adapt to help us ensure smooth running of a case and a good outcome. An effective team brief, really important. Mini brief, as we've already said, is perhaps even more important here. And things like using sims, modeling, these can also be really useful as well. But I think what we tend to do, at least in the NHS anyway, is when anything new is introduced, is we just go, surprise, here's the new robot, everybody go off and have a go. So we need to, again, think ahead, plan for these situations before they just sort of just happen or are thrust upon us. The discussion so far has been about optimizing team effectiveness, not just for the benefit of individuals within the team, but also with a view to improving patient outcomes. But I wanted to finish the last part of the talk talking about this now. Adverse events occur, and sometimes error, unfortunately, has tragic effects on patients, but there's also an effect on the surgeon as well as the second casualty of the event. And after an adverse event, surgeons typically describe feelings of guilt, shame, embarrassment, and also whether the adverse event relates to an error or a recognized complication also affects the way in which we process it. So errors seem to hit people harder and have more of an impact than complication. Individual resilience is a factor, and there's obviously lots of different things which contribute to that. I think when discussing resilience, I'll do this in a moment as well, there are generally speaking a couple of different sort of theories or perspectives. The first one is that sort of chipping away, that can only take so many hits before we start to crumble. And the second one is that through experience, we get tougher, error gets easier to manage, but I'm not sure that's true actually. The Royal College of Surgeons has put together a document looking at this and supporting surgeons following an adverse event. Excuse me. And they found hospital organisations reasonably good at fulfilling their statutory obligations, such as duty of candour, adverse events investigations, but they were either incapable or unwilling of supporting surgeons through the process. So simple things like, should you come to work the next day after a major complication? And if so, what sort of things should you be doing? Should you do exactly the same operation again? They also looked at how the process and support for surgeons could be improved. And they gathered stakeholders from places like the British Medical Association, psychologists, Royal College of Surgeons councils, medical defence organisations. And they looked at what would a better response look like. They identified things like peer-to-peer support programs, so talking to other surgeons or designated surgeons after the event. And they focused entirely on the surgical well-being when considering their recommendations, which was refreshing. I'm not going to make this interactive because it's too difficult on Zoom, but this is Tim O'Brien. He's a renal surgeon from Guy's and St Thomas's Hospital in London, and he's the ex-British Association of Urological Surgeons president. And he's been interviewed specifically on this topic of surgical error. And I thought some of his insights are quite interesting and just food for thought, really. He says that one way to mitigate against the impact of an adverse event is to be a very high volume surgeon. Because when you have a complication, you don't beat yourself up wondering whether you were the right person to be doing the case. You don't have that thought, should I have referred it to somebody else? That question doesn't really arise. So in his opinion, being a high volume surgeon reduces the chances of an error occurring, but also the potential impact of that error. His other comment on this is that it can be particularly challenging when a complication or error happens when working in a broken or suboptimal system. Again, I've got the NHS in mind. I shouldn't NHS bash too much. It's a fantastic organisation, but there are issues. So when you're working in an environment when the scrub team's always changing, do you have the same anaesthetist? And particularly, if you don't always feel as though you've got the support of the organisation behind you, I think it can be particularly difficult. So some of the things you can do or consider for yourself, again, from Mr. O'Brien, he suggested a few things to consider that may help reduce the chances of a surgical adverse event and the impacts of it. So the first one is dual consultant operating for certain cases. So all complex major surgery at Guy's in London are dual consultant lists. So you don't carry all of the responsibility yourself. He thinks it really helps reducing complications, but also improving our ability to deal with the complications. Second thing is, if you book it, you do it. Pooled waiting lists are a disaster. Do you really understand the case if you didn't book it? That might not be such an issue in Canada, but definitely in the UK, we have a lot of pooled waiting lists where patients will see somebody in the department, usually in the same subspecialty, and they sort of get booked by agreement on a pooled waiting list, so it could land on anybody's list, but that surgeon may never have sort of seen the patient or spoken to the patient beforehand. Next thing is anaesthetic surgical pairings. Some work, some don't work. And he mentions this term pause for gauze. So he made a change to his practice, he said. I think he's had one major sponge incident when he was told the count was correct, but it wasn't correct at the end of an op. And so as a consequence of that, he thinks it's critical to give nurses time to concentrate, to get their counts right at the end. And he often tells registrars, residents who are trying to grab needles to close the abdomen just to wait and give the nurses a bit of time. So that's just one change that he's made as well to his practice after an adverse event. I wanted to briefly mention resilience as well. So resilience is simply described as the ability to bounce back, really. It's been looked at as a potential focal point for around preparing surgeons for adverse events. Are people, how much of a factor is resilience, and how can we adjust for this or help people, or develop strategies to augment this? But the way in which we think about resilience itself is important. So early research on resilience thought it was quite a fixed personality trait, but more modern perspectives believe it's a dynamic process that can fluctuate with context. So by focusing on resilience, that in itself locates the source of the problem within the individual, for good and for bad. So it's been argued that for doctors, that approach shifts the blame and responsibility for doctors' struggles away from what are often over-politicized or understaffed, underfunded, badly organized systems and onto the individual. And in doing so, emphasis on the need for personal resilience sort of becomes yet another stick to beat surgeons with, and that surgeons are given the message either by colleagues, managers, or professional bodies, explicitly or implicitly, that they shouldn't be struggling, that they should be resilient, but it's a personal failing if they're not. And this belief appears to be more common in the way that trainee surgeons think about themselves. And I think these views are rooted in a misunderstanding of the nature of resilience. No one can simply decide to be resilient. Resilience isn't a fixed trait that a surgeon has or doesn't have. And actually, contrary to popular belief, medical professionals have been found to have relatively lower levels of resilience compared to the general population. And this correlates with adverse outcomes for both doctors and for patients. So the idea that psychological difficulties are purely a result of organizational system issues or wholly individual factors, I think is an oversimplification. A response should address building individual resilience and addressing organizational failures and factors as well. So how do you build individual resilience? I think this is still in relatively early phases, but groups have been looking at acceptance and commitment training to form part of resilience training for surgeons, which has some elements of CBT, but it's not CBT. There's also small pilot RCTs that have been tested as part of stress management and resilience training programs for physicians in the US. And there are also trial workshops happening in the UK as well. So it's just something that people are looking at. And I think this is all nicely set out and discussed in a bit more detail in this Royal College of Surgeons document, which I popped on the bottom of the slide here. At no point in my training has any of this ever been addressed, really. But it's going to happen to all of us. No other profession, I think, demands such a high level of performance, but offers so little to the well-being of its practitioners. We are extremely expensive, and we cost a lot of money when we're broken, and we should be prepared and protected better to do the work we're expected to do. And I think the other thing is we need to talk about it as well, just open discussion about it, and if possible, reflect and learn from it. And I go back to Neil Oakley again as an example of this. He's, by his own admission, he's had most of the complications during his career that I think there are to have. And one of the things we were discussing one day is a major pelvic bleed that he had during a lymph node dissection robotically years ago. And back then he used to film his cases. So the next time we were in the OR together, he brought his laptop in and we watched that video of his vascular complication. And it was really useful sitting down and having him sort of narrate it, telling me, I made this mistake here, then I compounded that mistake by making another mistake here, and then you should all watch a bit further as he gets himself out of trouble. But those sort of learning sort of moments or little vignettes are really invaluable, particularly for trainee surgeons, I think. So getting towards the end now, the General Medical Council, in terms of how we move forward, have started to train investigators on human factors. And this was in part brought about by a quite infamous case in the UK a number of years ago, when a paediatric junior doctor was held responsible for the tragic death of a young boy. And she was convicted of manslaughter and struck off the medical register. And this was later overturned on appeal following a lot of support from the public, medical profession. And the circumstances around the case revealed that actually the junior doctor had returned from an extended leave of absence without any graded reinduction back into work. 3 other medical colleagues were absent for much of a shift. There was an IT systems failure at a critical time, and she also had to deal with a number of other seriously ill children. So errors need to be considered in the context with which they occur. The GMC now recommends junior doctor training in human factors. And for the first time this year, a sort of a non-technical skills teaching session was included in my own urology trainee annual teaching programme in my area, in my region in Yorkshire in the UK, alongside all the normal prostate cancers, stones, all the other bits that form the teaching programme. So now human factors has found its way in all non-technical skills. And the final thing to say is that error is normal. People make on average 5 to 7 mistakes a day, and it's usually multifactorial. And I'll just leave you to consider, after hearing what you've heard, whether you agree with these words from the British rock band Chumbawamba, from their chart-topping song Tub Thumping in the late 1990s, which I'm sure you all remember. And then there's a couple of reference slides at the end. That's it. Thank you very much.